special seminar that is being offered in conjunction with our T32 Postdoctoral Training Center. It's my pleasure to introduce Dr. John Whyte to you. He's the director of the Rehabilitation Research Institute in Elkins Park, Pennsylvania, which is outside of Philadelphia. MRRI is the endowed research arm of Rehabilitation Hospital and is an internationally known center of research excellence, particularly in the area of cognitive neuroscience and cognitive rehabilitation. Dr. Whyte's primary interest is cognitive impairment resulting from brain injury, including pharmacological rehabilitation of attention deficits that occur after traumatic brain injury, attention and working memory, and recovery from prolonged unconsciousness. Dr. Whyte is also recognized for his expertise in methodological issues and challenges that are posed by rehabilitation research, as well as in research career development of rehabilitation scientists, such as those currently being trained in our TREET program. Dr. Whyte is board certified in physical medicine and rehabilitation and has teaching appointments at Jefferson Medical College and Temple University School of Medicine. Please help me and help me to welcome Dr. John Whyte.
Thanks, Florence. I'm pleased to be invited. I'm pleased to be a consultant on this training grant and to have made it across the country in time to give this talk, which was a bit touch and go. So, I was asked to talk about an area that I've been thinking about and writing about for the last couple of years related to treatment theory and rehabilitation. But this kind of merges with another topic that I've been interested in over a similar period of time, which is essentially the developmental pathway that treatment research often needs to go through, from some early idea to a funded big trial and ultimately a practical treatment that can be adopted by healthcare systems and so on. And as I've started to think about these two topics, they intertwine, in particular about what kinds of theories are relevant at what points in the maturation of a treatment research program. And that also has some relevance, as I'll talk about with the T32 fellows, to implications for career development. What skills do you need to have if you're planning to see a treatment through all the way from its origination to its implementation? Is that realistic? If not, where should one place oneself and concentrate? So I know a few of you have heard me speak at other conferences. You may have heard pieces of what I'm going to talk about today. I'm going to try to intertwine them in a moderately coherent way, and if they're not entirely coherent, I think there will be time in discussion for you to get me to be more coherent. So the things that I'm going to sort of go through in the course of the talk are, first of all, the notion that clinical research often is, and probably usually should be, a developmental process, the pharmaceutical model that we have in place for such a developmental process, and the ways in which it does and doesn't apply easily to the world of rehabilitation treatment. I want to talk about the translational process itself and what it entails, and the risk points for translational failure, the much discussed fact that many treatments get to a certain point of maturation and then just stall, and why that might be. Then I'll turn to the topics that I've spent more time on in the past, treatment theory and enablement theory, and how they inform that treatment development research trajectory, and then, as I said, some implications for training. So in the pharmaceutical model, we have a fairly stereotyped set of stages, and investigators in drug research are quick to say, oh, this is a phase 2 trial, this is a phase 2A trial, and they all know what they're talking about. Roughly speaking, people don't really talk about phase 0, but we can apply that to where the idea came from. before it's been subjected to any research in humans. So it might have come from an animal model, it might be a designer molecule that's of interest for theoretical reasons, but somehow we get this thing that we want to test. In phase 1, in the pharmaceutical trials, it is devoted primarily to safety and dose finding, generally conducted with a small number of healthy subjects. We're just interested in how much of this drug can I give before something bad happens to constrain my treatment studies with patients. In phase 2, we're beginning to look at early evidence for efficacy in a way that we think of as proof of principle. In general, this means that this drug seems to be doing what I thought it should. It seems to be having the physiologic effects that I predicted of it. Not necessarily that it's solving a real big clinical, practical problem yet, but it looks like it's the drug I was hoping for. This is usually a fairly small, often single-site study. There may not even be a control group if it's a condition with a well-known natural history. Then we get into phase 3, which is the traditional multi-center randomized controlled trial, where we're looking at the effect of the drug on clinically meaningful endpoints, survival, symptoms of some kind, and so forth. Now, different people would quibble about whether this is an efficacy trial or an effectiveness trial. Some people, particularly in pharma, say it's an effectiveness trial because it involves a lot of centers and a lot of people. I would say it's still really an efficacy trial because it typically involves very selected centers with well-trained and quality-controlled investigators and patients who still don't have all-comer type comorbidities but are relatively purified sample. So then effectiveness really doesn't happen in a formal way in our system. It happens after marketing of the drug, and we hear about people having an excess of heart attacks when they take a COX-2 inhibitor, and then we dig into it and blah, blah, blah. But that's really outside of the formal process. So in this model, it's assumed, and it's essentially required by the FDA, that a drug pass through these stages before it gets sold as beneficial for a particular purpose. Why? Well, drug development is expensive and risky. So these sequential steps serve to sort of filter the treatments. Let's get rid of the dangerous ones before we kill a lot of people. Let's make sure that the thing that we spend a lot of money testing in many different hospitals is worth the effort, and so on and so forth. Now, importantly, from my perspective, current drug research continues to make use of placebos in situations where I think that the research questions have moved beyond, is this better than nothing? Particularly in my center, where we have a large psychiatric program, most of the new drug treatments for schizophrenia and bipolar disorders are still tested against placebos, even though it seems to me like the question is this any better than what we already have, not is this better than nothing at all? Now in rehabilitation, I think we have similar phases, but they have some important differences. So we need ideas to come from somewhere. They come from a lot of different places in rehabilitation. They may come from other patient populations than the one we're interested in rehabilitating. They may come from animal models. They may come from theory, but they don't as frequently come from sort of designer drug type of approaches. Safety and dose finding. For better or worse, we tend to regard safety as not as big a deal in much of rehabilitation. Although Leslie Gonzalez-Rothi, among others, has said, if you think it's strong enough to positively affect the central nervous system, you ought to think it's strong enough to negatively affect the central nervous system as well. But for better or for worse, we have tended not to adopt a strategy that first says, how dangerous is this thing before we move on. Proof of principle needs to establish that this treatment does the thing that I expect of it, just like pharma research. But I'm going to come back a little bit later to what should we expect from this treatment at this point, and therefore what should be the outcome measures that would be the yardsticks for efficacy at this point in our trajectory. And I would say that we don't yet want or need measures of practical utility. We need measures that show that the treatment does the thing that it is mechanistically argued to do. But I'll come back to it. Large-scale efficacy, once we know that the treatment does something and we've had a chance to play with the treatment to make it as potent and efficient and cheap as possible, now we want to deliver it to lots of people and see it behaves the way we expect it to, pretty generally in the hands of most practitioners as delivered to most patients. But I would argue still at this point we should be logical about the claims we make for the treatment. It's still only going to treat the thing it's capable of treating, which sounds obvious, but I think you'll see shortly that it's not that obvious. But lastly, and probably the biggest hurdle for us in rehabilitation, we need to establish that this treatment has meaningful real-world impact in some group of people. And I view this last step as having more to do with characterizing some group of people than optimizing the treatment. So there's the best treatment you can invent for spasticity will not help a person who doesn't have spasticity, and will not help a person who has spasticity and no active movement, whose life goal is active movement. So what a treatment can do is not everything, and who it will therefore help in a big way depends on who needs the thing it can do. Okay, now let's just take a diversion a little bit and talk about translational research. Translational research refers to translating usually the findings of basic research into medical practice and therefore meaningful health outcomes. But that right away poses as many questions as it resolves. What's basic research? What do we mean by that? As long as I've been in research, I'm never quite sure what people are referring to when they say basic research. Sometimes they mean molecular. Sometimes they mean not people. Sometimes they mean I have a robust theory that transcends the messiness of individual people. So it can mean a lot of different things. In this context, I like to define it as model-based research. In other words, research that is operating in a domain of theory that has predictions that are made from the theory, and that is therefore more than the empirical study of whether something does or doesn't happen, but whether the happening of that something informs us about the theory that underlies that phenomenon. So in other words, I want to include things like cognitive psychology for my purposes as a basic science that I can apply to real-world behavioral issues, even though it's far from a molecular science. Well, what's medical practice? In this broad definition, it means the diagnostic tests and assessments and the treatments that are actually used. And then meaningful health outcomes, that's probably the most multi-determined, because many health outcomes are meaningful to someone, but of course they need to be meaningful to the people who matter, whether that's the people who matter because they want the treatment, the patient, the caregiver, the person who wants to pay for the treatment or not pay for the treatment, or whatever. But someone has to feel that this is worth undertaking. Now, in writings about translational research, it's widely agreed that there are specific obstacles where the research trajectory is at risk of stalling. And this is one diagram taken from a recent article that I wrote with Anna Barrett, which attempts to look at three described translational obstacles. So here we have the sort of origins of ideas as well as our understanding of a clinical condition, and we bring these two together for the earliest phases of human testing. So this would be the phase 1 kind of testing in pharma research. Well, here's obstacle number 1, because if the human has a different set of cellular receptors than the animal who existed in the model, then we may be affected differently by the drug. We may not metabolize the drug. It may be not effective. It may be dangerous, whatever. But there's, whoops, uh-oh, I think I just, oh, there. So something, can be quite a chasm, and if things don't go as planned here, we may just say, oh, not something we should pursue anymore. Now, we may then get a treatment that looks safe and possibly effective, and we move it into early clinical testing. But then here we have the fact that the drug has been shown to be effective, and now the question is, will rank-and-file practitioners adopt it in treatment? Up until now, they've been treating this disorder in one way. Now they have to start treating it in a different and better way because there's this new treatment available. Except that a ton of research has suggested that just because I tell you this new treatment is better than the one you're using will have virtually no effect on your probability of using it. Well, the problem is this translational obstacle has very little to do with the science of the treatment or the science of the physiologic or psychological system being treated. This translational obstacle has to do with human behavior and resistance to change and diffusion of innovation and a variety of more social, psychological, and sociological phenomena that have to do with how professional people decide to do something different one day compared to what they did before. Not something that the sophisticated theorists about the treatment are necessarily going to have very useful strategies for overcoming. Now, the last obstacle is one which I think I have sort of coined in the context of discussion of enablement theory, which I'm going to come back to, which is this issue that I now have this treatment that is very effective at doing a particular thing, and now I give it to a bunch of people and they don't go back to work and they don't report higher quality of life and they don't live independently and they don't join the PTA and they don't do all kinds of wonderful functioning that I hoped for. Why not? And I'm going to argue that that has, again, very little to do with the treatment per se. All right, now here's where we get to those two bodies of theory that I think are relevant to kind of unpack that a little bit. What I've referred to in sort of two broad buckets as treatment theory and enablement theory. Now, if you start with ICF, and it doesn't have to be ICF, it could be any of the earlier models that understand that functioning exists at a bunch of levels from organs to whole people in interaction with environment and so on and so forth. So we know that by some kind of nomenclature, there are these different levels or different perspectives on human function. We know in treatment theory, we think of this as specifying the mechanism by which a proposed treatment changes the immediate treatment target. And I'm going to apply a technical nomenclature to this immediate treatment target and call it the object of treatment, analogous to the object of a verb in a sentence. So this is the thing that the treatment actually changes or pushes or alters in some way. So the treatment theory basically defines what ingredients that treatment has to have in order to have that effect on the treatment object. Now, there may be additional active ingredients that can strengthen that effect or detract from that effect, but the essential ingredients in this terminology are what define this as this treatment, not some other treatment. Now, the problem for us in rehabilitation is that these treatment theories come from a million different domains. There's not a body of theory that we apply to rehabilitation. There's theories from neuroscience, from cognitive psychology, from biomechanics, you know, you name it, and we apply them all. So we have to have a way to think of them all. So let me just give you some sort of half-baked examples of what theories in different domains might be. So let's take a group of treatments that we could call progressive resistance exercises. And we'll say that the object for these treatments is muscle strength or torque. And that the essential ingredients are something like repetitive contraction against increasing resistance. Now, so just to unpack that a little bit, what this is saying is if you lift something once every couple years, you don't get stronger. If you lift something of a given weight 1,000,000 times, you might get a little stronger, but you stop getting progressively stronger. So what's required to get you to be progressively stronger is both repetition and increasing demand. Researchers in Canada identified a promising treatment for something called goal neglect, where people start off on a task and then sort of peter out and lose track of what they're doing and don't complete it. They trained patients, when you hear a tone, this random tone, that means you should ask yourself, stop, what am I doing? So all they taught them was, bing, whenever you hear bing, stop, what are you supposed to be doing? And then they found that when they play that bing randomly during tasks, they get more work done. So here we might say that the essential ingredients are a randomly delivered interrupting stimulus with previously trained significance. So the theory argues that if you never told them what that bing is supposed to make them do, it would just be an annoying bing. It needs to have significance that they are trained in. I could be wrong, but that's my theory. And so on. I won't keep going. But the point is, for each class of treatment, we could identify both what it's directly altering and what must be true about its activity or ingredients for that to happen. And that's all viewed as under treatment theory. Now, these potential additional active ingredients, which are not defining, might be things that alter motivational for treatment. So goal setting, reinforcement, stuff like that. Different forms of performance feedback. Do you get magnified information about your errors that gives you more ability to correct them? Those kinds of things. So those may operate across a range of different treatments, but they're not going to be defining to any one. Well, what are some implications of treatment theory? Well, first of all, the theory can be wrong. It's only a theory. But I think it's better to have a well-articulated theory that can be right or wrong than not to quite know what your theory is.
Well, I have a question. What if your theory is based on principles? So when I looked at your regressive resistive exercise example, if progressive resistive exercise is based on principles of exercise that increase power versus strength, then force production, you could say that the more you base your theory on principles, the less likely your theory will be wrong.
Well, yeah, I guess I don't really view principles as different from theory. They are a already established part of theory that I am building more on. So yes, it is always better to have a theory that's not picked out of the air, that is built on a foundation. And sometimes we may extend that theory. Maybe the foundation is right, but the extension is wrong, right? And we might find that out in terms of research. But I guess what I'm really distinguishing this from is, let's see if this works, where the answer will be yes or no, but there is no scientific principle or question that's just been tested. We just say, let's do that treatment some more, it looks good, or let's stop doing that treatment, it doesn't work. But we haven't learned anything about, in general, why something works or doesn't work. And that's really the advantage of theory-based. And the theories can be pretty rudimentary. They are in some cases. Now, the important thing about theory also here is that it groups together things that are the same. So I, for example, this will be a topic near and dear to an OT's heart. Do we have dressing training and grooming training and transfer training, and I mean, do we have as many kinds of, are those all different treatments that are, and we then have an infinite number of those treatments because there are an infinite number of activities we might train a person? Or would it make more sense to think about an approach to training sequential multi-step tasks? And that, the treatment is that, and it can be applied to a wide range of multi-step tasks in pretty much standard form. Now we went from having 100 treatments to having a treatment with some flexible parameters. That's important because we are likely to find out that certain principles of training make training more efficient for grooming and dressing and blah, 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 blah. And do we really want to do 100 separate RCTs about every possible thing you could train a person, or do we want to establish those principles as generally effective? Now, admittedly, this object of treatment is still a little bit slippery, because I can say this is the thing that the treatment directly alters. So let's say I talk about progressive resistance. The treatment directly alters muscle strength. Well, it alters biochemical and electrophysiologic events that allow me to recruit more muscle strength. There's undoubtedly a chain of events that ultimately lead to the torque. How do I decide where in that chain? For now, I'm just going to say that if for the purposes of this argument, we don't care about those links, and those links are pretty stereotypic and tightly bound, we're going to package them all together and say nothing hinges on them. There might be times when something would hinge on them, like in this patient population, the link from improved neural recruitment to improved torque doesn't play out as normal, therefore I need to break those steps apart. Now, switch gears to enablement theory. Enablement theory addresses the causal interrelationships among variables at different levels in the ICF. So it addresses questions like, if we improve a particular impairment, never mind how, what effects do we expect elsewhere in the system? If I improve muscle strength, what's that going to do to your walking? What's that going to do to your fatigue? What's that going to do to your vocational performance? It's asking questions like that. So here, we're acknowledging that the target of treatment, meaning that the reason that I'm actually bringing this person into treatment, might not be the object. It might not be that I deeply care about muscle torque. It might be that I deeply care about ambulation. That's my clinical target. Nevertheless, it's not the object of my treatment, and I have to grapple with that mismatch. So the target of treatment is often distal to the object of treatment. So here, I need to depend on enablement theory. There's no point in doing strengthening exercises if there's no link between leg strength and ambulation, and that's my goal. That would be a waste of time. So I need to know what's the relationship between leg strength and ambulation in order to motivate that treatment. And this is an oft reprinted diagram of mine kind of illustrating that point, that if I do a treatment that is supposed to enhance sustained attention, but my reason for doing it is to enhance employment, I have to think about the fact that there are intermediate levels. This person needs to be able to drive and speak in public to be employed. Sustained attention is relevant to driving and public speaking, but so are many other capacities. And this person may get really attentive, but still not be able to speak in public because they've got a language deficit, and I didn't do anything about that. So there's by no means a straight line going from here to here that I can depend on. And so what I have to do implicitly is model where these arrows are and model some kind of weights on them that specifies how important these different connections are. So enablement theory is essentially a specification of where those arrows are and what weights should be placed on them. Obviously, a variable at a higher level is generally related to multiple variables at lower levels, so it isn't a one-to-one correspondence. And therefore, the impact of changing one variable in a lower place is potentially very modest on a higher variable, depending on the weights and the number of different arrows impinging. Now, I don't think we're going to develop an enablement model of all of human life, where every capacity has arrows running to every possible activity and so on. But that's the concept, and I think we can build it in local areas. We can understand what are the critical capacities for walking, or for being able to organize your home routine, or da-da-da-da. Now, again, just to give a couple of examples here, where we can think of no matter how high or low we start. So here I'm starting with a very macro function, employment as a long-distance truck driver, or a rather micro one, being able to point to a target. But either way, I can unpack them into multiple smaller units. So employment as a long-distance truck driver, I need to be able to drive, read maps, maintain my wakefulness, engage in verbal and written communication, blah, blah, blah. So there's a lot more than driving at stake. But even pointing to a target, I need to be able to visually detect the target. I need to have the strength to raise my arm, the strength or the coordination to direct my hand where it needs to go to get the target, and so on and so forth. So there's always this nesting problem to be grappled with one way or another. What do these bodies of theory buy us? Treatment theory gives us tools for change. How do we change something in the ICF framework? But it doesn't tell us anything about the value or the impact of making that change. So what it does is it constrains the treatment. What does this treatment have to have? It helps constrain the type of subject that can respond to this treatment. So given that this treatment requires the following process in that person's brain, they better have the circuitry to undergo that process. And it allows selection of outcome measures because I'm going to pick things that are closely tied to that object of treatment, to the thing that this treatment can actually claim credit for changing. Those are going to be the most powerful evidence for proof of principle.
But,
and, yeah.
I've seen treatment theories that do have within them hierarchies that suggest that first, by doing this treatment, you're building a foundation, and that foundation leads to a different kind of functioning in the brain or something. I mean, it has nothing to do with the ICF. So there are treatment theories that I think have embedded proximal and distal
Yes, I think that's
kinds of outcomes.
Yeah, I think that's right. I mean, I think you can think about, especially, yes, treatments that look at layered capacities,
Exactly.
where you need a foundation. So, you know, hypothetically, you couldn't have coordination until you have some basic level of strength. So if you were wanting coordination, you'd first have a module to get them out of complete flaccidity, and then you'd move on to something else. I guess I haven't thought too much about that. I think that I think potentially you could break those into two separate treatments. Does the first phase of that achieve an outcome, and the second phase of that wants patients who have that capacity as appropriate patients, right? In other words, this coordination treatment requires that you can move. Oops, you can't move, you should have that other treatment first. That's one scenario. I think it depends partly on whether you expect these two processes to be kind of linked all the time in everyone. Whereas in the case of when I'm looking at the difference between treatment theory and enablement theory, the problem is that different people have different combinations of deficits. And so everyone that you treat might experience an improvement in the treatment object, but different people will experience different amounts of improvement in some distal thing because they have different arrows broken, right? So let me give you an example from the physical world of spasticity, which was one of the early examples that I looked at. People are very frustrated. Clinicians are often treating spasticity because they want active function, right? So they are implicitly drawing a line between spasticity and some positive aspect of motor control, coordination, dexterity, power, whatever, okay? They treat the spasticity, they say, oops, they didn't get better at dressing and walking, the treatment wasn't very good. And then they go and look for another drug that will be better, more powerful, right? This is an example where I think the failure to separate these two things has slowed the field. If you look at the outcome, if you look at outcome for spasticity treatment as elimination of positive symptoms of the upper motor neuron syndrome, stiffness, hyperactive deep tendon reflexes, clonus, and so on, you find that just about every drug works pretty well. It's just that solving those problems doesn't magically make people skilled movers. And to me, that suggests that the upper motor neuron, I didn't invent this, the upper motor neuron syndrome is a syndrome with multiple manifestations, one of which is spasticity, which is not terribly strongly causally related to things like recruitment, dexterity, coordination, and so on. Therefore, you take it away, you don't give any other treatment, nothing big happens on the active movement side. If, however, your goal was to allow you to separate that person's knees for perineal hygiene, or to stop their feet from flying off the footrest, you'd say that was an effective treatment, because now your clinical target was a positive symptom of spasticity, which that was an effective treatment for. So I would argue that there the problem was poor enablement theory, poor conceptualization of where does spasticity sit in this syndrome, and what realistically could we expect elimination of spasticity to achieve. And I, for one, would argue that looking for a stronger drug is going to be barking up the same old tree. Okay, so enablement theory does predict what will happen elsewhere if we change something, but it doesn't provide tools for change. It doesn't say, how do you make attention better? How do you make strength better? How do you do anything like that? Moreover, it doesn't really care how you did it. The predictions of enablement theory will be the same if I have increased muscle torque, whether I got that from exercises, from injection of trophic factor, from electrical stimulation, or from whatever, because the input is just what's the torque, not how to get there. So here, it constrains subject selection for effectiveness research. We don't want to pick people, if we're going to test effectiveness of spasticity drugs on real-world function, we don't want to pick people who have such terrible motor control that they couldn't do anything with or without their spasticity. That's not a good population. And it constrains outcome measures. Do we want to propose increased employment in that trial? Is that a realistic expectation? So to give you this somewhat more fleshed out example, imagine now that we have this local enablement model with certain capacities and weights, and this is our study treatment. Well, this study treatment is strongly linked to reading, but rather weakly linked to walking. And so if I use walking as an outcome variable, I'd be on better grounds if I did that with treatment A, which is strongly related to walking, than if I do that as treatment B, that is rather weakly related to walking. So I should pick reading as my sort of real-world outcome for this treatment if I'm giving just one treatment. That's the treatment, that's the outcome that will be most strongly related to it in the most people. Now, we can deliver rehabilitation treatments at any of these ICF levels, right? We can change structure, function, activity, or participation. And we can also measure those outcomes at any of those levels. When we measure the two at the same level, we have the most analytic power because we're directly measuring the thing that we treated. There isn't that gap, that enablement gap where we lose explanatory power. But much of what we do in rehabilitation is up in this area where we're treating at a lower level, hoping for a higher level impact. And there we can't avoid thinking about enablement. Okay, actually, I just talked about this out of order. Let me just say, though, the thing that made this so interesting to me was that I did this evidence-based review in an era when we weren't calling them evidence-based reviews, and we're so primitive they were on 3x5 cards, my studies. But the good thing that that did was allow me to sort those 3x5 cards. I had spasticity studies about a bunch of medications in a bunch of patient populations with a bunch of paradigms, a bunch of outcome measures, blah, 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 blah. Chaos. Some worked, some didn't work, some worked, some didn't work. My goal was to sort them in such a way that there was coherence. And the thing that was like an aha moment for me was didn't work to sort by patient group, by chronicity, by drug. What worked was to sort by outcome measure. And when I sorted by outcome measures that were passive, i.e. Stiffness, reflexes, and so on, all the drugs worked in all the patient populations. I mean, that's only a slight exaggeration. When the outcome measures were active movement, ADLs, gait, skilled activities, no drug worked in any patient population at any time. So that made it very clear that there was something going on here with where different outcome measures sat and what they were really measuring. Okay, now I want to try to put these two themes together a little bit at this point and talk about how we merge our notions of theories with the developmental sequence. And this has some particular interesting discussions that we will probably have a chance to come back to in a training program that is heavily focused on controlled trials, because I view controlled trials as occupying a niche in a trajectory, but not the whole trajectory. So how do we get treatments ready for clinical trials? Somebody's got to do that. And where do we take them after clinical trials? Somebody's got to do that too. So if we think not in this lockstep phase 1, 2, 3, and 4, but the purposes in early stages, we're looking at proof of concept and early clinical efficacy. So we're developing a treatment. Does this treatment act the way my theory thought it did? Does this seem to work the way I expect? And then partly I find that out by saying, does it seem to have the beneficial changes on the object that I predict? That's the beginning of, so that's the early efficacy. And I would argue that at this early point, we want to demonstrate that the treatment alters the desired object. We shouldn't feel on the block for demonstrating that it is practically useful, beneficial, improves quality of life, and sends people back to work. It's too early to expect that. What we argued in our theory is these ingredients change this variable. Let's measure this variable and see if that's true. Now, often in this early phase, we're going to find that it does change this variable, but not that much. So now there's going to be potentially some iterative cycles of how can we make it change it as powerfully as possible? How can we maximize the potency? So are there ways through some serial investigations in terms of how we schedule the treatment, how much feedback we give, how it's structured, whatever. We have to, obviously our theory gives us some ideas of where there's room for manipulation, but we want the thing that we ultimately test in a more practical way to be the best thing we can come up with. And it's very unlikely that the first iteration is that thing. So just as there is dose optimization in pharmacologic research, we need something like that, but it's much more challenging in rehabilitation, especially if the treatment is delivered over a long period of time and has long-term effects. Is it the one-year outcome that should be used to judge what's the strongest form of the therapy? Then it takes me a really long time to compare one-year outcomes. Yeah.
Just, John, but as an original person, I would say that in rehabilitation that also presumes that we have assessment tools that are sensitive enough to change and really measure the thing and the object precisely and sensitively enough to actually detect the change that the intervention may or may not be producing.
Indeed, and I think that that's a good point, because I think that we have reasonably well-developed tools for many of the normative activities that we want people to re-adopt. But those are always going to be distal to most of the things we treat. There are many, I mean, in my area, cognition, measuring the cognitive processes distinct from measuring the activities people can do when they have those cognitive processes is in itself a very thorny issue. There's no direct measure of visual perception. I have to get you to do an activity that requires it and see that you make mistakes, and then I say, aha, you have a deficit in visual perception. So yes, we may need, for this approach to research, we actually may need more measures at the kind of molecular, I don't mean that literally, but impairment kind of level that are sensitive to change. So now we have developed a treatment that is, seems to behave the way we expect and seems to be powerful enough to be interested in. That was all done with reference to treatment theory. Now I move into what I'll call the middle stages, where I'm trying to get to efficacy and to early effectiveness. Here still we rely largely on treatment theory, but we begin to bring in some contributions of enablement theory. So a couple things happen here. First of all, just to do efficacy, we still want to know whether more than John Whyte with these 10 patients that I know really well can make something happen. We want to know that it can be distilled in a form that can be delivered by multiple people and that it has about the same effect no matter who has it. I would still argue that the best yardstick for does it have about the same power when you do it and when I do it is that treatment object measure, because that's the thing it has responsibility for changing, so it's the most direct measure of how well it did that. But now we're going to want to begin to ask questions that lead toward its clinical benefit. We can't go on forever testing things and say, yeah, I'll worry later about whether it does anybody any good. So we begin to ask, what kinds of people is this treatment likely to have practical benefit for? And I think the easiest group to begin with is people for whom that is their predominant problem. So to take a patient with attention problems and brain injury, who also has big behavior problems, blindness, ataxia, dysarthria, and then say, okay, I'm going to treat their attention problems and see how they do, is probably not the best place to start. So I might want to pick people who have mild deficits in other domains and who identify attention as their most significant clinical problem, or something like that. Because now it is more likely that I'll be able to pick up broader positive impacts of the treatment when it's 90% of what's wrong with them rather than 1% of what's wrong, if you will. In later stages, where we're moving into effectiveness and health services research, this relies primarily on enablement theory. So at some point, I'm going to start having to treat attention problems in people who have blindness and ataxia and behavior problems, because that's what we do, right? How am I going to grapple with that? Well, most people would not at this point think about, let's treat attention problems. They think about, let's treat the range of problems that this person has. We start putting together a treatment program that has multiple ingredients, not necessarily for everyone, but multiple available ingredients. And we put together some sort of assessment algorithm that assesses what a person's problems are and says, you have big problems in A, C, and D, you're going to get those 3 treatments. You have big problems in B, C, and D, you're going to get those treatments. So there's some systematic linkage between assessment findings and treatment results. And then, if you will, I'm looking at the effectiveness of the collection of treatments and the system for allocating them to individual people, and asking whether that package has, now it's reasonable to expect that package to have impact on things like independence, quality of life, return to work, whatever, because I'm targeting a range of coexisting deficits in the same person. Someone who did an approach like this very elegantly, although I haven't tuned back into her research of late, was Mary Tonetti at an earlier point in her Falls research, where people had been saying, oh, old people fall because they have weak ankles. No, they fall because they're on drugs. No, they fall because they can't see. No, they fall because... And probably we think they fall because of some or many of the above reasons in different combinations in different people. So she took this approach which said, not let's give everyone a bunch of treatments, but let's give an assessment and allocate people to medication simplification, vision testing and remediation, take the rugs off the floor, blah, 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 depending. And she was able to show that that package algorithm had a larger impact on fall reduction than the prior programs that picked a thing and gave it to everybody.
I have a question.
Yeah.
A packaged algorithm. I know what a package is, and I think the interventions that we develop here are packaged complex interventions with components. But why the word algorithm? Is there some mathematical way that she figured out who would get what?
Well, I think all I meant to imply with algorithm is that it's not the same package for everyone.
Okay, she didn't have some equation that she used.
She had a flow chart that had, if your score is over X, you get it. If your score is below X, you don't get it.
Okay.
Yeah. But I think that can be contrasted with many complex interventions where it is assumed that all the participants, roughly speaking, need all the ingredients. They may come from different theoretical places, but the notion is that everyone will benefit from all of them. That can be true, but that would be different from this kind of assessment and allocation strategy, which is more similar to the traditional, let's do our initial assessment and then decide what the treatment should be, but it puts more structure on that process.
But as you think of it, separate modules, so to speak, or the essential components, let's say in Tonetti's, where she has visual, like her different package things, moving the rugs and
Right.
visual, right? Do you consider each of those an active ingredient? Or
I consider each of those a different treatment.
a different treatment with different active ingredients?
Yes, because reducing psychoactive drugs is, no, she didn't articulate the theory for each one of them, but I would say that has something to do with balance and alertness issues. Those are the objects of treatment there, whereas ankle strengthening exercises have a different object that is presumably to be able to respond to perturbations in a rapid and powerful way, blah, blah, blah. So those are separate treatments that are grouped together for a common purpose in people who need them. Yeah.
But if there were some guiding principles over which selection was made for incorporating various facets, then would those principles be the active ingredients? I mean, whatever, or that theory?
Well,
That's what I'm,
yeah,
and we can talk about this later, but I'm not clear.
No, I'm happy to, I mean, you know, I will make my thinking clear before your eyes as you ask me probing questions. So, well, first of all, ingredients are always things that can be experienced by the patient, not things that are in the mind of the practitioner and how we're thinking about them. So a principle can never be an ingredient. The thing that happens to the patient, the thing that the patient experiences, i.e. there's a rug that's gone, that's an ingredient. We in our work on taxonomy, which I'm not talking about here today, but it infiltrates, it's generally the case that things that change objects that are in different systems have to have different theories. So the theory by which your vestibular system is changed is different than the theory about how your ankle muscles get stronger. And so as soon as you say, I'm trying to strengthen the ankle or I'm trying to improve vestibular function, you're already separating into two different mechanistic theories. And then what you're saying in your big picture is, I think there are people who fall down when they try to walk, who do that for different reasons in an enablement model. And depending on the arrows that are busted for them for smooth and effective walking, they're going to need different arrows in that diagram strengthened to get the common outcome of safe and independent walking or whatever. Does that help?
It helps. It does help, especially when the ingredients are things that are experienced by the patient. That helps a lot.
Okay.
That helps a lot.
Okay, good. Okay, so I want to leave plenty of time for more chat. So I'm going to just move through the last part, which is just to talk about how these theoretical frames help us, especially in the early phases of research. Help us to define the treatment, to select the participants, to select the outcome measures, and to select the design. So in terms of defining the treatment, well, why does it matter to define it? Well, for sure, to allow research on efficacy and effectiveness. What are we studying the efficacy of? And you'd be surprised how often a thing that has more or less the same name gets studied in several studies, and it's a different thing each time. And then it's very hard to aggregate the results of that research. We want to be able to replicate encouraging findings. Can't do it unless we can take that treatment and move it somewhere else. Once we have something that works, we want to be able to educate and train clinicians. What are we training them in? Now, the least important but nice thing would be if it facilitates coding and billing and stuff like that. Oh, I gave them 3 hours of X, and we know what X is. Why is it challenging? Well, of course, few rehabilitation treatments can be defined by a chemical formula like drugs. That's the easiest. Some are devices that have multiple attributes. So in our taxonomy work, we got into this really interesting conversation about whether a cane is a cane is a cane, or whether a cane is a member of a class of rigid vertical objects that can bear weight. Because really, the principles of the essential ingredients of a cane are something about it being stiff and vertical and you being able to put pressure on it. And from that point, canes break into a lot of different kinds of canes that are used to solve different problems and stuff. So, or a handheld electronic device is, I would say, is not a treatment. If you program it for reminding, that function is a treatment. If you program it for, storing stuff, that's another treatment. It's just a gizmo. And then some treatments are voluntary and interactive or experiential. So I can't define, as a clinician, the treatment I give without knowing what you did in return and what I did next and what you did next. And, it's a reciprocal chain. So that affects how tightly I can define it in a moment-to-moment fashion. Now, in previous research, these have been huge problems because a lot of our research has used contact hours with a type of facility or a type of discipline as the definition of treatment. Well, many of us think it matters how you spend your time in that session in that hospital, but we don't seem to measure it very often. Then there's intent-based, and this is where I get to the forceful answer to Florence's question. The clinician, the patient, doesn't know my intent necessarily. So this cannot be an active ingredient in their receipt of treatment. And what we got into was this kind of almost comical discussion. We walked into a treatment setting where a therapist was throwing a ball back and forth with a patient, and we're trying to think, okay, what is being treated here? And then, you ask the therapist and say, eye-hand coordination. Okay. But then you come back another day, there's ball tossing back and forth. What's being treated? Social interaction. Okay. And then you come back another day, what's being treated? Dynamic balance, right? Okay, so is the treatment ball tossing? Is the treatment what the therapist has in mind when they toss the ball? Where is the definition of that treatment to be found? So we especially want to avoid intent-based definitions, as though as long as I have your welfare at heart, I'm giving you the treatment. It can't be that simple. And then the most recent refinement of intent-based definitions has come out of this practice-based evidence network of folks who've done studies now in stroke, TBI, spinal cord injury, and I think joint replacement. This is a more microscopic frame on intent-based, where people get together and they do put some flesh on it. So we do something called partial body weight supported gait training. Oh, what is that? Well, that's when we have this harness and this da-da-da-da. And now we have a thing that people agree, and it's more than just, I hope they walk better. But we don't know, for example, whether the error feedback that you give people during that task is relevant or not. There's still no specification of what's critical about that. Is it just hanging in a harness and then nothing else matters, etc. Now, theory-based definitions. So consider a patient with limitation in active shoulder range of motion. We could pick a bunch of specific treatments like ring stacking, putting dishes on high shelves, reaching to higher and higher numbered stripes on the wall, repeated, or we could call those all repeated reaching movements at end range. In other words, if we say that the theory about how these treatments work is that they stretch tissues at the end of their range, then all those things above become just different ways of doing the same treatment. Now that's a stance, right? I could say, no, it's incredibly different what you stack and why, but then I need a theory that makes them incredibly different. But you see how the way we formulate these theories can collapse or divide different experiences into one or multiple treatment. And if you think about it in analogous to pharmaceuticals, you wouldn't want to say we have some small red pills and we have large white capsules and we have bitter liquids. Those are our treatments. You'd want to say what's the chemical formula in there, and it might be that there's the same chemical in the red pill and the large white capsule. And it might be that there are two kinds of red pills that do very different things. Once we get these kinds of theory-based treatment definitions, then empirical data on efficacy or inefficacy not only gives us some practical information about the value of that treatment, it helps to support or refute the treatment theory, and it builds the science of treatment. So whole classes of treatments can be supported or undermined by research on a specific treatment. And I think the act of arriving at a treatment theory helps to identify good candidates for the treatment and what likely outcomes of the treatment should be. So we can select the participants because we've said, well, let's take a concrete example, constraint-induced movement therapy. If your theory of how this works is it allows discovery of hidden movement potential, which is one of the theories, right? That people soon after stroke discover they can't do anything, so they stop trying. Meanwhile, their underlying motor function gets better, they don't know it, and now they need the experience of discovering that they have preserved function. If that's the accurate theory, then it would be not a good idea to take somebody with a very severe stroke and put them through this, because what they will discover is, yeah, I rediscovered it, I really can't move, right? On the other hand, if the theory behind constraint-induced movement were experience-based plasticity, then there's not an obvious point where, oh, you're too bad, you can't have plasticity anymore. That theory would invite a more continuous notion of the relationship between severity and the impact of the treatment. So there's an example where the empirical results of treatment under certain conditions could help us understand how that treatment works, and then further extend who it's likely to work for. I'm going to move ahead. Well, it also obviously, when we work toward developing treatment manuals, we need to decide what to include in the manual. Should I include the day of the week, the size of the room, the clothing of the therapist? No, I should include the things that are essential ingredients. I have to know what those are. And if I'm doing a randomized trial and there's another comparison condition, I need to make sure that those ingredients are not in that comparison condition. And that can be thorny, because some of the ingredients, if we haven't thought carefully about them, may be common to both and may undermine the contrast between them. And then just on the outcome side, what outcomes do we expect to be changed? The ones we are most clear on are the treatment objects as specified by the treatment theory. But then it's really important that the outcome measures in our clinical trial be well suited. And I've seen this frequently mishandled in cognitive rehabilitation research, where someone develops a treatment which they may not say very clearly, but I feel I can tell from reading it, is a compensatory treatment. So it's given that your memory is shot, here's how to get the job done, right? Then at the end of the treatment, we give them a standardized neuropsychological memory test as a measure of improvement. But the strategy we taught them was list making and calendar keeping and organizing, and in the neuropsychological test, you can't do any of that. Why would they improve? So it's not mapped onto the mechanism of action, the selection of an outcome measure. And I think I'm going to stop there, because the rest of this we can, I'll say one more thing. The one thing that I want to spend a second on is this issue of placebo or sham. Because in the world of RCTs, like nowhere else, everyone wants a placebo comparison. And I'm just going to have to smack those grant reviewers upside the head, because a placebo means a fully plausible treatment that is completely lacking in the active ingredients. Right? Now that can be achieved with a chemical, because as long as it's the right color and it doesn't have any sensory cues, it's fully plausible and it's inert. But imagine the fully plausible treatment for your memory deficit that couldn't possibly help your memory deficit. So it has to be something that seems to you like it's very relevant to memory, seems to engage with the things that you want to remember, seems to be relevant to your memory failures, but couldn't possibly help you at all. Well, good luck. As soon as you're talking about your actual problems and how they manifest, you're into active ingredient territory. And so I think we have to become more flexible, not that research should be uncontrolled, but that the control comparisons need to be specific to the question at hand and not cover any possible treatment impact of any ingredient that might come down the path. So I'm going to stop there. We have some time left, and I'd be happy to flesh out more of this in response to the discussion.
I was just thinking about your example of developing the treatment theory. You mentioned reaching stacking cones, reaching positions, but you sort of characterize them all as reaching to the full extent of movement. But as an OT, I would say that, yes, that's what all of those are working on. But if there's one or reaching for dishes is really meaningful for Florence because she makes dinner every night and she puts dishes away versus stacking cones means absolutely nothing to her. Do you then separate that little meaning piece out as a separate treatment?
Well, I'm just smiling because we kind of previewed this discussion a little bit over lunch. That I agree with you that environment and meaning are important, but I think we should unpack how they're important and when they're important. So I would argue, and I'd be happy to have you argue back, but I would argue that if Florence reaches her arm just as far, whether you give her a ring or a dish, then with respect to the tight tissues of her shoulder, those are identical treatments. I.e., I don't know that there's anywhere that meaning is communicated to the joint capsule. But if I am, for example, giving a home instruction, these are exercises I want you to do at home, and I could choose between I want you to reach for a yardstick that says so and so many inches, or I want you to, do you have a high shelf in your kitchen? Could you stack? Maybe she will be more likely to do those exercises if she sees the meaning and the context. But that's then a different ingredient. That's a motivational ingredient that affects performance of a trained home program, not an active ingredient that affects the sensibility of joint tissues. And in fact, in our taxonomy work, this has been a really interesting thing to think about because a lot of what rehabilitation therapists do is education for a remote intervention, right? A lot of what we do is tell people how to do something that they're going to do elsewhere. And we've made a decision in our taxonomy work to say that your treatment is the thing that happened between you and the patient. So if you instruct someone in strengthening exercises, your treatment was an educational treatment. It was not a strengthening treatment. Now, you happen to instruct them in an activity that will have therapeutic benefit of its own, and we can sort of nest these, right? We did that because we want to put you on the hot seat for the efficacy of your treatment in motivating performance of those exercises. That's what you have control over, is whether you can get her to do them at home, not whether they will be effective when she does them at home. That's a separate question. So there's a place where the motivational component, the meaning component, is potentially very critical. Does that make sense?
Mm-hmm.
Other?
So there's a, first of all, this was extremely clear and well presented, and I'm very much aligned with your treatment theory, enablement theory approach. I think it's really the direction that we need to go. But there is an entirely different approach to clinical research that is, I think, emerging, that would kind of sort of say, well, we don't need to do all of that. We can actually start at the end, and we can get out all our number crunchers and start to look at what's actually happening. And a lot of this is called classification research and all these things. So let's just take these huge masses of data that we have, and these people have been treated with this, and these people have been treated with that, and what worked, what didn't. We can begin to subgroup the patients, and after a while we know we don't need theory, is what a lot of people are saying. And indeed, I think a lot of that is coming because as you've pointed out, it's hard work to do these treatment theory, enablement theory. I mean, there's a lot of development that needs to go into that, and when these studies take months and years to do, because we've got all these great computers now, we've got these databases, we can do all this. So I don't know. Back pain is, in our field, back pain is where this is really being pressed, you know, classification of patients and that sort of thing.
Yeah, well, I mean, I have some sympathy for that approach, but I think that approach works best when there are already discrete things that you can count, right? So in some areas of medicine that rely heavily on drugs and devices, there's no controversy about what the patient got. They got this drug, this dose, this day, not that day. They got a pressure mattress, they got a specialized wheelchair, they got this kind of indwelling catheter. Okay. And then I agree that with a large enough sample and with enough sort of confounding variable items that might help you disentangle why this person got this and that person got that, that might have also biased the outcome, all that stuff, there's some room. So I think the jury is out about how much forward movement will come from the more sort of brute force empirical approach versus the more
Theory-based,
beginning to
I would
end,
hope.
yeah, theory. But I see that as really hard to apply to most areas of rehabilitation right now because the countable things are hours of a discipline.
Well, it's being done though.
Well,
I mean,
right,
in
if
that
all,
way.
if all you want to know is how many hours is good, but that will never tell you how to spend those hours. So you have to end up with coded contents of some kind in order to do the work you're proposing beyond the level of you should have 7 hours of treatment, I don't care what you do. And then the question is, what's the initial coding strategy to allow that to happen? And that's where we take a big risk, because if we invest a lot of clerical administrative time in carving up what we did in a way that turns out not to map onto active ingredients, then we will have tons of data on stuff that won't work out. So, you know, where I'm, so I guess I'm in the camp that thinks that at least for a period of time, we need some work to conceptualize what we do in active ingredient terms so that it's represented and defined in ways that can be counted in more observational ways as well. I mean, I'll give you an example of where I think this is really key. In our taxonomy work, I obviously should have talked about our taxonomy project, is very relevant here. We've come up with large clumps of theory, which we're currently referring to as theory groupings. These are not by any means single theories, but broad classes of theories that are relevant to different domains. And it probably won't surprise you if you think for more than a nanosecond that one of the very largest theory groupings is learning-based treatments, because a ton of what we do involves repeated performance of something with some kind of feedback and support and information to varying degrees and so on. Okay. It is right now typically talked about in terms of the thing you're trying to get a person to be better at doing, as I mentioned before. So, you know, there's gait training and reaching training and blah, 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 blah. It seems very likely to me that there will be certain underlying learning principles that apply broadly, right? What's the optimal mix of errorful performance versus errorless performance, and what does that depend on? What forms of feedback about performance, that is, to what degree does goal setting of what you want to achieve, what effect does that have? What does feedback about how it's unfolding have? What does terminal feedback about whether you achieved the desired outcome? How do those things interplay? What about declarative, stepwise treatments versus more continuous, skill-like thing. You know, so it seems to me that the action in those treatments is not to carve this up into 1,000 skills that we want to teach, but to develop notions of learning-based treatments that optimize some of these parameters and probably optimize them differently for different broad types of performance improvement. And then once we do that, I think the type of work you're talking about will maybe not be, did they get X, yes or no, but how much performance feedback did they get? How many repetitions did they get? You know, what the units might turn out to be more like continuous dimension units than, you know, penicillin versus sulfa drug.
But the solution of that problem probably won't come from studying learning, but from studying tasks. I mean, in other words, what we know about learning is that it is task dependent. And so what we need is to understand how to classify tasks, which is in effect what a taxonomy does. So there are no principles of learning that can be applied to any task. I mean, that's those of us who study motor learning, for example, know that that's the first rule of motor learning, is that it depends on the task. But there are tasks that are similar to each other, and there are tasks that are dissimilar, and some rules apply to certain classes of tasks. And so
well,
what are those classes of tasks?
Yeah, but keep in mind there's also kinds of patients here too. So patients who have memories and patients who don't have memories. Patients who have intact proprioceptive inputs as they perform tasks, and patients who don't. So I agree with you. I mean, to the extent that the treatment object is a class of tasks, I mean, there's no treatment that's effective for everything. So we're going to end up saying, if you want to train patients with memory impairments in sequential stepwise tasks, it would behoove you to maximize these ingredients and minimize those ingredients. So that's not going to be a general truth about everything. It's going to be a truth that is contingent on attributes of the patient and attributes of the task domain. And
the stage at which the patient is in the learning of that task, which is the time dimension is which you mentioned is the other critical dimension.
And indeed, we have to, from that perspective, we have to grapple with some treatments where the goal appears to be not per se to improve performance, but to minimize the effort required for that performance. So to make something more automatic, more smooth, more effortless in its performance. But that too has attributes that make it likely to be achieved rather than continued effortful performance and stuff.
How do you deal with the social aspect of therapeutic interaction? That it's a social relationship, and that, you know, that seems to me it's an active ingredient of something, right? In everything, it's ubiquitous. There's always, unless you're doing robots, but then that's also a different kind of.
And the robots have social
They do,
attributes
right.
too.
So what about that? I mean, having done a lot of trials, I'm very particular about who gets to be the therapist.
Yeah.
And that's not, you know, talked about as an active ingredient. How do you deal with that?
Yeah, no, I think that's a good point. And I would say, I mean, how we're dealing with it right now is probably overly rigid and simplistic. But I'll tell you how we're dealing with it right now, which is to treat it in a similar fashion to what I said about environment, i.e. that different therapists can get people to do different amounts of things and things at different levels of challenge. And so our first move would be to say, if you get the person to partake of the essential ingredients of this treatment, then they got the treatment. If you are an annoying dictator and they say, you, I'm out of here, that's the level at which that would operate. Now, the reason that I say that I already know that that's probably overly simplistic is by thinking about the analogy to psychotherapy, where psychotherapy went through a lot of the same agonies that rehabilitation is going through, where people would articulate schools of thought for what is therapeutic and then compare two or more of them and find that the effects were pretty similar, and then, oh, does this mean nothing works? And then I think most of the field of psychotherapy has moved on to not nothing works, but lots of things work. And then why do lots of things work? Because we were wrong about what some of the most active ingredients really are, and that in psychotherapy, what are referred to now as the common factors, things like empathy, collaborative relationship, shared goal setting of the purpose of treatment, you know, blah, blah, blah. I'm not an expert on this, but those things turn out to be common moves of people who are psychodynamic, cognitive behavior, Rogerian, you know, whatever label they apply to themselves, they do those things and they get good results. So there may be aspects, I mean, for sure, if we open up the notion of treatment to include the stuff that it really does include, like which things are important to you to work on and why, what's the most meaningful for you, what do you want to, what do you feel like working on today? You know, there are all kinds of interpersonal things that may be more than just motivational. You may learn that a person has a problem that you wouldn't have learned if you were a non-empathic therapist, because they wouldn't have told you, and now you make an actual different decision about treatment because you have access to a piece of information. So I think there are those pieces too, and we've completely put aside for the moment the assessment process for the taxonomy work, which we recognize is hugely important, but it's important in all areas of healthcare, and it still doesn't affect whether something is or is not effective when it is appropriately selected. That's still a meaningful question.
I just have a probably simplistic comment, and that is that when I hear this discussion, and sometimes it escalates to a quasi argument in certain meetings about what's the best method for studying outcomes. It seems to me all of the above, because the clinical prediction rules that have come from studying these large aggregates of patient outcomes have been extraordinarily helpful in terms of treatment. Triage systems for heart attacks and emergency rooms are a good example, just studying huge databases and coming up with sorting based on who recovers, who needs to be admitted to intensive care, etc. So it seems like these different approaches can inform each other, and that waiting for just, or putting all the efforts into assumption and theory-based may not be the only way to approach this, but simultaneously getting these very large databases and sorting them can inform our assumptions that, as we know, and you point out, have often been incorrect, spasticity being a great example.
Yeah, no, I definitely agree with that, and I think that partly my choice of topics emerges out of kind of a historic pendulum swing that's happened during my career, which is, I mean, it used to drive me nuts reading the archives of the MRRI. I would joke about, you know, another study of does A work better than B? You know, it's just like time after time, let's compare it to treatments. And it just felt to me like we're going to be doing this forever because there's an infinite number of treatments, and what did I learn besides don't do that? You know, so partly I wanted to call attention to the value of theory, which I think is underdeveloped in rehabilitation, and partly because of the heterogeneity of the domains from which we can draw theories. And then also with the more recent push to, we need randomized controlled trials, it's like, I think a bunch of people, well, when DOD put out their money for TBI, you had people who invented a treatment yesterday and we're going to do a multi-center RCT tomorrow, because because we need the evidence. But you know, those RCTs are very likely to fail, and then we don't have the evidence one way or another. So I'm really focusing on theory because in some sense I feel like it's been the neglected member. But I do want to sort of reiterate the point that I made in response to this comment, which is I just am not certain that exploration of the huge databases will be as richly rewarding in rehabilitation, because what's in those databases? You know, even in a messy community setting, heart attacks, there's an entry to the emergency room, they did or didn't go to the ICU, they did or didn't get aspirin, they did or didn't get a beta blocker, they did or didn't, you know, blah, blah, there's a time in which those things happen. A lot of the potential active ingredients are coded reasonably well, and now it's ours to sift through them, whereas they went into the rehabilitation hospital and God knows what happened to them there is, you know, tougher.
In terms of your enablement theory, I was just curious if you're interested or looking at how strengths might alter those pathways and those parameters. I thought it was interesting to think about the link between impairments and moving up to some functional kind of outcome that you wanted. And it seemed that sort of looking at which part of the package people should get based on the nature of the distribution of the problem and where you're headed. I was wondering if you think there's value in looking at times when strengths actually trump or would alter those trajectories, and if it's something that is possible to communicate.
Yeah, I definitely agree that strengths and not just impairments or weaknesses are relevant. I guess the question is, I mean, one thing, of course, at a simplistic level is that those arrows can be either, right? I mean, they're the thing that if you lost it would be very important, or the thing that because you have it, it's very important. What's not in the model, I mean, this isn't the model, it's not in this schematic of a model, that might get closer is these are nonlinear relationships. And that's, I mean, as if it wasn't complicated enough. Just take a simple example of extensor strength and stair climbing. And I'm just making this up, but I think it must be true. If I am paralyzed, I can't climb stairs. If I increase my leg extensor strength in a continuous manner, there's a range of increase where I still won't be able to climb stairs. Then there's a range where as my strength further increases, now I'm starting to climb stairs. Now there's a range above a certain point where I don't climb stairs any better because I'm immensely strong. I just still can climb stairs. So it's going to be a sort of sigmoidal kind of function, right? So there's that, and then there's interactions, you know. So, you know, if I have a little pain plus good strength, I can do X. If I have a lot of pain and good strength, maybe I can't, you know, et cetera, et cetera. So I think that might be where strengths, how strengths appear sort of empirically, that if you have enough of this thing, then loss of this thing doesn't affect the next level, but you'd have to draw some sort of interaction there.
Do you want to say something before? Oops, because I always throw something on. I just want to say thank you. I know I'm cutting you off quickly because Danny is very compulsive about time, unlike me. But I do want to say that how lucky are we that Dr. John Whyte agreed to be a special mentor of our T32 fellows. It's just great to feel that in any way we are connected to you, that we have a real connection. And I'd actually been dreaming of that for years before I called him. And I remember calling him to ask him if he would do this. And I said, do you know who I am? I'm Florence Clark. And I said, I did the well elderly, and he said, I know who you are. And I was just so amazed that you did. But anyhow, I had always hoped that I would be able to work with him because for years I've been benefiting from his publications. And now I'm so happy that our next generation of career scientists produced here will have the opportunity to learn from him. This was a wonderful presentation.
And I'm happy someone read my article.
Well, it's great. Someone who speaks our language is here. So it's great. It's wonderful.